members for this panel discussion. Dr. Vinod sir, please sir, and Dr. Bala sir, please join the chair session sir. Dr. Sugavanam sir, Dr. Anup Jurani, and Dr. Dhanashekhar Raja sir. Dr. Anup sir, he's not there. I think he will join later. Please start the session.
So, without much ado, I think there's been a lot of buzz around panel, around the alignments of total knee arthroplasty. So, we thought we'll have this panel discussion.
Dr. Anup, sir, please join the chair session.
Dr. Anup, please come for the panel discussion. So, this is on alignment of TK. We know that we've been hearing a lot of terms regarding mechanical, anatomic, kinematic, as was well demonstrated by Dr. Anup, inverse kinematic, restricted kinematic, adjusted, and functional. Now, like we said, things have evolved over a period of time, and I think Dhanashekhar also said from the 1980s to now, we have come to functional alignment, from constitutional or mechanical to functional alignment. Now, this is how it's changed, and mechanical, we know that it's a systematic approach to total knee, and mechanical basically means that it is perpendicular to the mechanical axis. However, Bellemans in 2012 with this paper pointed out that there could be what is called constitutional varus, and that is what this subset of patients will not be happy with restoration of mechanical alignment. Now, we'll start from this end of the panel, Bala and the rest. Do we do long leg x-rays as routine, and do we calculate the angles preoperatively? Bala, Vinod, and...
I do long leg X-rays routinely.
Okay.
But
angles?
I don't measure angles preoperatively.
Okay. LDFA, Dhanashekhar? Vinod first.
Yeah, same thing. Long leg X-rays you do, but don't measure every time.
Okay.
Measure the angles.
So previously, when we were doing mechanical alignment, I took long leg X-rays and calculated the valgus correction angle for the femoral side.
Correct.
Tibial side, I used to draw the long axis and then make the changes to do a perpendicular tibial cut. But now I'm relying more on MPT and LDFA.
LDFA.
Yeah, the same.
Same. Anup, I know you're a robotic person, but we'll stick to the normal. Yes.
So this is
Mike. Yeah.
yeah. So long leg X-ray is always in a standardized fashion, but draw the line up to the calcaneum.
To the calcaneum.
Latest
yes.
research has shown that is where the ground reaction force is. So not up to the talus, but up to the calcaneum.
Up to the calcaneum.
And that differs. That will differ the MPTA.
Yes. What about the stress views, Dr. Anup? The stress views, do you rely or do you ask them as a routine? Suppose you have a significant varus. Would you ask for a stress view?
No, because lot changes after anesthesia and
Yes.
lot changes after removal of osteophytes. Okay. So I would not.
Anybody on the panel does stress views, or do you think the importance of the stress views?
There is I would like to ask Anup one question. He's telling up to the calcaneum. If you find there is hindfoot varus or valgus, what do? You do compensate in the knee, or?
That's right. You need to. In case you think that the patient is not going to go for a valgus correction, you need to offset that on the knee alignment. And most of our patients, elderly, have a hindfoot valgus.
They do have a hindfoot valgus.
Yes.
And they point that out actually before the total knee, and we tell them that if it's significant, it may require correction later.
That's right.
So I would differ from this. I would not compensate in the knee. If it is flexible deformity...
No, I think most of us what we do... Yeah, go on.
Flexible deformity, it is going to get corrected automatically once you do the knee replacement. If the fixed deformity, we give a shoe correction. If it is beyond that, then we do a osteotomy.
Yeah, and when they come back later.
Yeah.
Correct. So, we know that there is some loss of the degenerative... with the degenerative loss, there is loss of medial space, but there is no change in the LDFA and the MPTA. So this is what I think led to the calculation of what we call the HKA and the joint line obliquity. So when we talk of a neutral, we need to introduce some terms. And I start with Dr. Anup. So basically we introduced this term called HKA and the joint line obliquity. We know that the neutral joint line, which means 180, is plus or minus 3 degrees. And the neutral HKA is plus or minus 2 degrees. So when we talk about the CPAC, or coming to what we call the CPAC, it refers to both the joint line obliquity and the HKA. So how do we calculate what is called the pre-arthritic value?
So in severe deformities, it may be difficult, as I was saying, to calculate accurately the MPTA. So best calculation is on the operating table by cutting equal amount of bone from the tibia medial and lateral, distal, medial, distal, lateral, and posterior, medial, posterior, lateral. That will restore your joint line to within 2 degrees.
Because most of the alignment strategies refer to what you call restoring one is constitutional, number 2 is pre-arthritic. So I think the question in everyone's mind is what is this pre-arthritic, or how do we calculate that? So in severe deformity, can we boldly say that it's difficult to calculate the pre-arthritic alignment?
On the tibial side,
On
yes.
the tibial side, yes.
Femur, no.
Femur, no. Okay. So we all know what the CPAC classification is all about, and we know that most of it, the 5 is the one where the joint line is absolutely parallel, and we know that most of them are clustered around 2, 3, or 1, 2, and 3, and the 5 is that's absolutely parallel. Now that the CPAC awareness has come in, Dr. Anup, we'll start with you and across the bank quickly. Do we do a CPAC assessment routinely preoperatively?
No, it's not mandatory with kinematic alignment. We do have a look at it, but we are not enslaved to it.
Not yet, just for
Not yet.
theoretical exercise.
You
We're
do
working
that,
on
yes.
few cases.
Dhanshekar and then Bala.
We routinely measure it and give some idea, because if you have proximal tibial valgus,
Okay.
your femoral component is almost like zero rotation and sometimes external rotation.
Yes.
So those are areas where it is helpful. I routinely use it.
Vinod?
Don't do routine assessment.
I don't do routinely.
So can we all say across the board that in our planning we don't routinely do, but what we are doing in a mechanical alignment is converting everything to a CPAC 5, correct?
That's right,
Yeah.
that's right.
Say across that.
That's
But
right.
so when we do this, we do not know what the CPACs are. This came out from McDessian group. Now we have one article from India that has said that the CPAC distribution is slightly different. And we have one in arthroplasty put out by Vigdokchip and group saying that there's significant variation in the CPAC distribution between countries. So it's good to know, I think, across the board, but I think we should be also aware that the original description put out by McDessian group is also not a concrete or universal application. Is that agreeable?
Yeah, and another critique of CPAC is that it's just looking at knee in a coronal plane.
Exactly, only
the
coronal
sagittal
plane
plane and
is
the
not
axial
considered.
plane is completely
Rotations.
neglected,
Exactly,
which probably is
exactly.
more important.
And more important, and this has come out just recently from Jonathan Vigdokchik, so I think we can all accept that good to know, but then there is a variation. So now we move across the various alignments. We want the kinematic. What would be your goal in kinematic alignment? Dr. Anup, you already elaborated it very well. So we are talking about restoring joint line obliquity. What about the CPAC variation? Do you want to restore it to what it was? Or the original CPAC, with reference to CPAC, or we just
As far as possible, but it can vary because you're not releasing any soft tissues.
Exactly.
So, and restoring the PCLs. So, one category here there may happen in kinematic alignment, because kinematic alignment is more about 3-dimensional alignment and not just coronal plane alignment.
So we can boldly say that kinematic alignment is femoral resurfacing, correct?
Correct, absolutely.
Yes, so just for understanding for everyone, to simplify things, it's femoral resurfacing. This was introduced by Howell in 2008, and to restore the pre-arthritic joint line, like you said, correct?
Absolutely, yeah.
Yes. So now we know that it can be done either with calipered measurement or with technology, correct? Now, can you give us a few tips? I think we'll talk, Dhanashekar, how to do it with a calipered technique.
So basically you resect equal bone from the distal femur. So for that you need to have either a valgus correction angle plus 2 degrees we add, and start with the resection, and we measure it. Once we are happy with the resection, I complete the resection. Both sides should be 9 mm. That's what implant we are going to put in. Posterior condyle should be parallel to the posterior condylar axis. Again, 8 mm from both the condyles.
So that brings us now to where Bala, Vinod and Sugumanam. Do we measure our resected bits as soon as we finish? Do we make that? Have we started doing that, or do we ever do that?
Yeah, we measure that, but we have already cut it.
Yes, but
Okay,
at least to be aware. Yes, it might be too
So
late, but
yeah.
have you started measuring, or have you incorporated that right now into your practice?
I'm a mechanical alignment fellow. So
But do you measure your cuts?
I measure.
You measure
to
your
have
cuts.
some
Bala
idea.
and Vinod?
I also do only mechanical alignment. So
But do you measure the cuts that
Yes.
you take? Okay. So this is a gross difference between mechanical and kinematic, I think the cuts wise at least. And I think there's a K algorithm there for release which is slightly different, because like Dr. Anup also pointed out, it's more of bony cuts that are used in kinematic alignment rather than soft tissue releases.
Because
correct?
there is no ligament contraction.
Exactly. So you're doing only bony cuts to adjust the gap. You're not doing any soft tissue releases.
That's right.
And as pointed out, we know so there is soft tissue respecting calipered alignment, and the calipered and soft tissue respect are referred to as unrestricted. Now, what about this concern of kinematic allowing too much of either extreme valgus or varus? I know restricted came in because of that. What about the implications of that?
So most studies, if you see, which compare kinematic to mechanical radiologically, have insignificant difference between the overall HKA. So while you're targeting mechanical alignment, you can still be in a degree of varus.
Okay.
And with kinematic, you will be in about 2 degree varus. So long studies, lot of patients have shown that the HKA in kinematic alignment is insignificantly different from HKA in mechanical alignment.
Okay. So that's where the concept of restricted kinematic alignment I think came, where the bone cuts are within the safe range. Correct? Sugumanam, anything?
Yeah.
Restricted kinematic alignment where we have bone cuts within the safe range, and intraoperative adjustment can be done only with technology, either with computer assistance or so. And there it's a femur first and aim to again restore the pre-arthritic, and LDFA, you have a target zone between 85 and 95. So for those of us who use technology, so do you check that once you make the cut, before the cut, after the cut?
No, it's a part of your planning.
It's a part of the planning.
It's a part of your planning. You will mark on a robotic screen or a navigation that you're cutting 8 and 6, measure it before, after, even after your cut, especially the distal femur cut.
Okay.
Because distal femur cut, you can sometimes on the medial side take 2-3 times. So you have to measure for the saw curve, or account for the saw curve as well.
What happens when you encounter extremely sclerotic bone? What happens when, do you take the saw curve is taken into consideration, but how many times have you had to recut, or how many have you had to adjust the cut because of the sclerotic changes?
Lot of times. So every time we will check. So suppose our original thing is 1.5 degree valgus and it's 0 degree. So I will cut more laterally to give it more valgus.
That does happen when the bone is very sclerotic. Happen.
Yeah, absolutely, it happens.
Okay. So in restricted kinematic for a varus knee, again you keep it between 5 to 8 degrees. Is that what we are trying to say?
The tibial side?
Yes.
Yeah.
Okay. And same way for a valgus knee, you would say the upper limit is 3 degrees?
The valgus on the femur?
No.
Yeah, Krishna wants to say something.
Yes, Krishna.
-5, plus or minus 5 degrees on the femur,
Yes.
plus or minus 5 on the tibia.
Exactly.
So what this is showing is, if the pre-op measurement is 8 degrees of varus,
Yes.
you adjust it to 5 degrees.
5 degrees, correct.
So you cannot accept 8 degrees of.
You cannot accept 8. Yeah.
But in unrestricted, you can accept 8 degrees of varus. So that's the difference between the two.
Usually not required, but
So inverse.
Problem with unrestricted is problem you have a metaphyseal bowing, gross
Yeah.
deformities. You don't balance, you don't, you try to recreate the anatomy. That's why this restricted kinematic came.
Okay.
Because you cannot do it for every patient.
Every patient.
see,
So then this
we should
concept-
not just look at the tibia. We have
Yes.
to look at the overall
Overall
HKA.
alignment.
Because the loading will happen not just on the tibia, but will happen overall.
So,
I think-
restricted kinematic, you have boundaries both in the femur and tibia.
And the tibia.
But you don't do balancing. You just recreate.
So then we came to the inverse, where the tibia is first, right? We go to the tibia first.
Yeah, tibia first.
So what
femur-
is your indication for an inverse kinematic now?
None.
None.
So I do it when patient has stiff knee. You're not able to correct the deformity fully. You anticipate posteromedial tightness.
Okay.
So that's where I start with the tibia and then do some adjustment in the femoral side.
So I think the last one that I'll talk about rather than going on is functional alignment. This obviously requires only intraoperative judgment of the spaces, correct? And then your cuts are based, or your balancing, or your bony cuts are based on intraoperative imaging and information assessed, correct?
Yeah, that's right. So preferable is to have a CT-based system where you can actually measure everything and have some kind of technology to implement functional alignment accurately,
Okay.
ideally.
Okay. So basically the sequence would be planning, use technology, cuts with robot or technology, and minimal soft tissue release, if at all, at the end. Correct? That's what we are advocating. So going through the different types of alignments, just to simplify it, we have mechanical, anatomical, that is already mentioned, kinematic, it's femoral resurfacing, just to simplify it, inverse kinematic, starts with the tibia. Your restricted kinematic basically has boundaries, and your functional alignment depends on what we achieve intraoperatively, or depends on information taken intraoperatively. So in effect, we have all the alignments where minimal release is done as you proceed on towards from kinematic onwards. Soft tissue release is minimal, correct?
That's right.
And that's what we have seen. And so distal cut again also varies, because the bony cuts are more as we go into the technology based alignments, and that's what we've seen. So this is the difference between all the alignments, where we also aim for some amount of undercorrection, or where, especially with the kinematic alignment, we aim for undercorrection. So would that simplify, if you were to say how kinematic alignment stands out from the rest?
No,
Would you
it's
say
not under correction. It's a absolutely rectangular extension gap, whatever it
but
takes
maintaining the joint line obliquity
maintaining the joint line. So whatever work you have to do on the tibia.
on the tibia only.
On the tibia. So you cannot accept any lateral laxity, or more
Exactly.
than a millimeter maybe.
So to simplify it for everyone, and just for simple understanding, you maintain the joint line obliquity, and also, which means it could be in varus, it could be in valgus, depending on the inherent angles, and no soft tissue release, correct?
That's right, including the PCL.
Now, this I'll just go through quickly some articles. This was in 2022. There's said implant and this current concepts in alignment, again by Jonathan Vigdorchik, saying that there are more personalized approach. This is an article that was in 2023. Even though the current alignment techniques are there is no clear winners yet. Again from Jonathan Vigdorchik and group. Functional alignment may improve resection accuracy, but long-term clinical trials are needed to investigate better results. And just to have an overview of how much robotic surgery has penetrated into various countries. I think even in the US it's only about 50%. Australia it's also about 50%. India is about 10%. So given the scenario across the panel, quickly, would we modify, or would we, knowing that majority are without technology as yet, would you advise mechanical with a combination with what we are aware of now with the other alignment strategies, or mechanical alignment with caution, starting from Bala and Vinod?
Well, I'm still following only mechanical, but only time will tell. I will switch over to kinematic.
No, given the fact that we are still, majority are non-technology users.
Yeah.
Has it changed the way you practice now that you're aware of all these things? You have CPAC, you have...
No, not yet.
Not yet.
Not.
Vinod?
Still, I've been using only mechanical. I don't have robot. But there are a lot of factors, not just the factors what you see in the literature. Many other factors which push you into taking up robotic technology.
Has it changed the way you handle soft tissues, at least for now, without technology?
Without technology, no, it hasn't changed.
Suguvanam, before I come to Dhanashekhar and Anup, who are obviously with technology.
Yeah, with all this technology, CPAC, all this discussion the last couple of years, certainly soft tissue release has become much, much less.
Less.
And I particularly use a buccal pepper system.
Sure.
Okay, which with
is
with
based
an
on-
rectangle established before you touch the tissue or the bone.
Anup
So-
and Dhanashekhar any other technology, so I don't need to,
Always, I think it's a great asset.
Asset.
It's not a prerequisite, but I think it's an asset.
So again, some more articles again by Marcus Arnold, Benjamin Skelka and group. It is basically impact of different alignment strategies in total knee. It gives you just a few more minutes. It estimates the joint line obliquity well. Inverse kinematic alignment accommodates native coronal alignment better, is what a recent paper said. Again, from the group Philip Wincock and the rest. Restricted kinematic alignment is clinically non-inferior, which means basically it's almost the same as mechanical. A systematic review this was. And again, maintaining joint line obliquity optimizes outcomes of functional alignment, which is again from Calapi and group. This says, so that means if you maintain the joint line obliquity, it's at least the short-term results, 2-year results are good. And further long-term data are required to ascertain the cost effectiveness of newer robotic systems. So in summary, might be mechanical is time tested, but kinematic is maybe universally acceptable for those who are accessible and less significant deformities. So this implants as of now don't require modifications, and just to know whether the alignment strategies actually are driven by technology. May not be, but I think we have a different way of looking at the alignment strategies itself. Okay, so obviously in gross deformities like this, you would do mechanical alignment. And at the end of the day, what we need is basically good range of movement. As long as the patient is satisfied and we are having a good range of movement, I think your alignment should also encompass the morphology, soft tissue, and alignment, whichever alignment strategy you use, whether it's mechanical, kinematic, or functional. There should be harmony between all three. 1 minute on patellar resurfacing. Bala and Vinod, do we do patellar resurfacing?
Never.
Never. Anup? No.
Yeah, 20% cases where I have full thickness bone loss, especially in a valgus knee where the shape is altered.
Okay. So I think recent articles have also said that regular resurfacing is not necessary, and clinical were not different between patellar resurfacing and non-resurfacing. So take home, and alignment knowledge has improved the awareness, lesser soft tissue releases probably, patellar, like Anup said, specific indications. Thank you. Thank you, panelists. Thank you, gentlemen, for this wonderful. Thank you.
Thank you, Anil sir, for a wonderful session moderating of this difficult topic. And I would like to thank all the panel members. The next session, it's on basically a complex and painful TKR. I would like to invite Dr. Pari Selvaraj and Dr. Karthik Selvaraj to chair the session. The first speaker will be Dr. Harish Bende sir. He'll be presenting managing extra-articular deformity, planning and execution. Welcome, sir. Thank you.
There is a small change in the schedule. Dr. Harish Binde's talk is going to be the first.
Let me thank Ortho-One team for inviting me here. It was a very heavy session with different types of alignment strategies being discussed. I don't know how many of you are still awake, but I like to make my lecture very simple. And let us talk about some basic thing and with a simple diagram, not with a complex charts and complex, different angles and different alignment things. So we talk about extra-articular deformity. Now, basically, we need to know exactly what is the scope, what is extra-articular deformity, why it happened, how it happens. And when we say about correcting extra-articular deformity, we have to initially know what is meant by intra-articular correction. So we discussed just the principles. So various reasons give you a deformed femur or deformed tibia. It could be trauma, it could be fracture, it could be stress fractures, osteoporosis, STO, etc. And you can get these weird type of pictures in your clinic. Now, basically, extra-articular deformity is a deformity which occurs outside the attachment of the collateral ligament of the knee. So when we do knee replacement surgery, we are cutting the bone within the limits of the attachment of collateral ligament, and then we can correct depending on how the articular surface is damaged. We take certain amount of cut, then create certain amount of gaps and try to balance those things. So if the gap or bone loss is within the articular surface, it is called intra-articular correction. But when there is a deformity outside because of fracture, osteotomy, old rickets, Paget disease, significant amount of bone bowing, then we need to decide it separately. So in principle, we first discuss about what is intra-articular correction. So you have got a varus knee like this. In a simple mechanical way, this is a mechanical axis of the tibia. That's a mechanical shape of the femur. And we normally is expected to take a standard 90-degree cut. We are talking about now simple mechanical alignment. Let's not confuse with the different types of alignment because it becomes much more complex later on. So we take a distal femoral cut, we take an upper tibial cut, which is mechanically at 90 degree to the mechanical axis. So we create some amount of gap between the two bones. And then we try to balance these by releasing the tissues on the medial or a lateral side, depending on whether it is a varus or a valgus deformity. If the distal cuts are taken at less than 90 degree, obviously the gaps will be little less unequal and we may have to do less amount of releases. But the bottom line is, After you take the cuts on the distal femur and upper tibia, there is an unequal gap and we have some way of balancing the gap. So you create the medial soft tissue equal to the lateral soft tissue in a case of varus deformity, and when the balance happens, automatically your alignment gets more or less straight or whatever you want. Now, if the deformity is quite significant, normally these cuts which we take are within the attachment of the collateral structure. You can see that that's the collateral attachment, and a distal femoral cut should be inside the attachment, which is roughly about 2 centimeters from the distal articular surface in most of the adult knees. Now, if you have got a deformity like this in the femur and you want to get this mechanical axis perpendicular or parallel to the tibial axis, and you take a cut perpendicular to this, then your cuts would be like this, which will be quite a significantly large cut on the femoral side. So automatically when you cut that much femur, your attachment may get disengaged and you automatically get laxity of the tissues on the side because you have taken a much bigger cut to account for the deformity in the femur. And that can cause laxity, it can cause instability in the tissue because of excessive bone cuts. On the other hand, suppose your cut still happens, the extra cut still happens within your collateral ligament, then to balance you have to release the opposite side. Now because you have created a huge amount of unequal gap, the amount of release which you have to do will be again significantly large, and in the bargain you may over release and make the medial side unstable. And this instability can cause because of excessive ligament release required because you have got abnormal cuts. So instead of having these two excessive cuts creating a huge gap, we have to decide whether I want to correct the deformity beforehand and correct my bone first, make it straight, more or less straight, and then I do my knee replacement surgery. And this can be done either at a time of knee replacement surgery if the deformity is very close to the joint surface. So you can take a osteotomy there, you can take a wedge cut, and you may use a long stem of the femoral component and correct the deformity properly. So when we try to correct the extra articular deformity at the joint level, it can lead to either excessive bone cut or excessive ligament release or both of them and cause instability. So in principle, if you correct it separately, then it is called extra-articular correction of deformity, and then the principle is whether you want to correct the extra-articular part as a separate stage surgery. So you do the operation in 2 stages. You correct the deformity first, tell the patient I want to make your deformed bone straight, and then a second stage few months down the line I do the knee replacement surgery, which will be much easier to do. But obviously it means 2 operations and no patient wants that. So many times surgeon wants to do both the stages together, and it is possible if the deformity is very close to the joint line. Now in principle, if the deformity is, say in case of varus, more than 15 degree extra-articular deformity, we cannot correct it at the level of the tibial tuberosity. You may have to take a separate tibial wedge osteotomy and then take a standard tibial implant with a long stem. Many times these extra-articular correction augmentation which are done may need an added external plate, so then it will be more stable. But if you do not use the extra articular plates and you additional stable implant, then this osteotomy may become loose, it may not heal very well, and eventually the entire surgery may develop complication and failure. So many articles have been published, they have mentioned about these using the extra long stem of the implant on the tibia or a femur, use a bone graft, use the additional fibular osteotomy, use a unicortical plate on these things to get the fixation. So it becomes a very massive surgery for a surgeon, and you have to be sure that you are experienced in doing and handling all these complicated cases. If you find it difficult, there is no harm in correcting the osteotomy. First, correct the deformity first, and maybe a few months down the line, you can do relatively a simple knee replacement surgery. If you don't do that, there is a significant risk of something going wrong, and this paper I mentioned 55% people not doing well at 2-year follow-up when they did not try to fix this extra-articular correction by added external plate in addition to the long rod which they had used. So let's take an example of one simple case here. This is an extra-articular deformity. Upper tibial valgus deformity was there, and we had to do a TKR in this patient. You can see that the deformity is quite significant, almost about 30-degree deformity. So we didn't want to correct it, because if we have to correct it intra-articularly, that should have been our cut. that was a very large cut on the medial side. So we decided to do in extra-articular correction. So this was a very old case. So we used to do planning on these X-ray, tracing papers. So we decided that we need so much amount of wedge to be taken at the level of the angle of the deformity, and on table we calculated the exact wedge, we remove the wedge, and then we can put the standard long stem. So the cut then becomes more or less what normal cut would be. I don't have to cut any extra bone on the tibia, and you can put a long stem. During this planning, we must make sure that when you do the planning of these wedge osteotomy of femur or tibia, make sure that there is no translatory effect of the osteotomy, and you are able to put the long stem properly into the distal fragment. And sometimes you have to add a fibular osteotomy, because fibula may allow or may not allow you to close the wedge which you are done. So this is a post-op X-ray. It fitted very well, there was no instability, so we didn't have to put an extra plate on the tibia. And you have to actually open this area and see that after putting the implant, your osteotomy site is also very stable. Otherwise, put an added external simple unicortical plate. So this alignment looks very good. So in nutshell, if there is an extra-articular deformity which needs correction, corrective osteotomy can be done. If the osteotomy is to be done and it is to be fixed with long stem, make sure it is stable. Otherwise, you can use added external plate. A deformity which is less than 15 degrees may be corrected at a bone cut level, because that much leeway usually most of the surgeons have. Thank you.
Hello. So with the advent of the 3D software, what we do now is all extra-articular deformities, we take it on a software, and we can create a jig. These jigs are going to give you a correction in all three axes. Sometimes what we do is, we just try to do the varus valgus correction, even in an extra-articular. While these extra-articular deformities do
rotation
have
also.
rotation also.
Yeah.
So you do a 3D planning, and when you do a 3D planning, then it also enables you to give a certain amount of correction which you can plan not only in the axis form, rotation form. You can design jigs for extra-articular, as well as you can have a TKR jigs as well designed in that. So this is what you can do when you have such complex cases.
Yeah, I agree. You are absolutely right. That is quite right. The only thing is, you need that technology to get the 3D assessment done. Then you have to create the 3D planning, and you need to decide the jigs. The basic principle is whether you want to correct the entire deformity at the joint line level, or you need an extra-articular correction also, is independent of your this. Maybe your accuracy of getting correction is much more with a computer-assisted or these 3D printing jigs. There is no question about that.
Yeah, so this is now available, and this can be done very much.
We can do
it
that.
It will reduce your surgical time and stress both. So you don't have to hackle much on that. You just open up, put the jig, do the osteotomy, do the correction, and you will exactly get what you had preoperatively planned. Yeah.
Any other question? Thank you.
Thank you very much, sir. We now call upon Dr. Krishna Kiran for his talk on managing flexion deformity.
Thank you, Yuvraj, for inviting me. So this is a pretty basic talk, but I'll raise certain fundamental questions regarding our understanding of the flexion deformity. I may be wrong as well. So we know that the causes are manifold, and the etiology will determine the management. So inflammatory arthritis must be managed separately. And the general principle for inflammatory arthritis is 1/3 of the deformity usually corrects during anesthesia, 1/3 you correct during surgery, and 1/3 corrects during rehab. But for hypertrophic osteoarthritis and post-traumatic arthritis, you must achieve complete correction on the table. Otherwise, it will not spontaneously correct later on. So any deformity more than 10 degrees you leave will automatically persist as a flexion deformity, and the patient will not be happy. What do we need to evaluate and assess? We want to assess whether it's a single plane deformity, that is, there is only a sagittal plane fixed flexion deformity, or is it a biplanar deformity? And if it's a biplanar deformity, whether it's a flexion varus or a flexion valgus. Is it correctable after the arthrotomy? So it's not a preoperative classification. You must do the arthrotomy and then decide whether it's a correctable flexion deformity or it's a non-correctable flexion deformity. And always look for posterior osteophytes on the X-ray because these are usually the culprits both on the tibia as well as the femur. So this is a classic inflammatory arthritis knee, and as I told you, the management is completely different. Hopefully, if time permits, I'll show you a video at the end. Now this is the traditional classification of flexion deformity. Grade 1 less than 10, grade 2 10 to 30, grade 3 more than 30. This is of no relevance because it will not help us in any which way. So once you do this arthrotomy only, you will know whether it's a correctable deformity and a non-correctable deformity. So that must be the thing. So if you have a biplanar deformity, the basic principle is that it is predominantly due to collateral contracture because the MCL and PCL have attachment posterior to the sagittal plane. So it's posterior to the midline. That is why any coronal plane deformity will automatically pull the knee into flexion deformity if it is a located knee. I'm not talking about subluxated knees. So sometimes in varus knees there is hyperextension and lateral subluxation. This is not the question. In patients where the knee is located, that means there is no subluxation, there will be usually a posterior osteophyte formation. There will be posterior osteophytes and the collateral contracture of the deep MCL, not the superficial MCL, and this will pull the knee into fixed flexion. And you must not go ahead and just do a additional distal femoral resection as is taught in the techniques, because we must be aware that most of the techniques for managing flexion deformity have been designed by surgeons who do posterior stabilized knees. So the first step for them will be cut less tibial cut with less slope, remove the PCL, upsize the femur. So that is not going to be valid in all the situations. Why? Because I'll come to that point. You just be with me on that particular point there. For femoral sizing, the conventional teaching is that you must cut the tibia with less slope and upsize the femoral component to stuff the flexion gap, because there is a flexion extension mismatch. In a flexion deformity, what happens? The flexion gap is larger, extension gap is lesser. That is why you want to overstuff the flexion gap by reducing the slope, upsizing the femoral component, and try and balance the extension gap by additional distal resection of the distal femur. Now, what is the role of PCL? So, what is the function of PCL? So, if you go back to the function of PCL, PCL is one of the flexion stabilizers. So, it is actually, if you remove the PCL, the flexion gap will further increase. So, in a flexion deformity, it is not a good idea to remove the PCL just straight away. So, it's a good idea to keep the PCL, because the PCL is not contracted or damaged in these situations. It is actually a stabilizer against flexion instability. So, now you take out the PCL, then you will have to do all those things, cutting, reducing the slope, cutting, upsizing the femur and all that. So, don't start with the premise that you have to cut less slope, you have to remove the, upsize the femur. First assess the PCL. So, do your, look at the deformity. It's a 40-degree inflammatory arthritis, different ball game. Osteoarthritis, 95% of the cases you can retain the PCL and do a cruciate retaining arthroplasty, and therefore additional distal femoral resection becomes a no-no in flexion deformities, because additional distal femoral resection by elevating the joint line changes the isometric point of the PCL and causes secondary PCL tightness. So, most of the surgeons, they will cut 4 mm distal femur additionally, PCL becomes tight, and then they will sacrifice it and do a PS knee. You get this point? So, don't get it wrong. The PCL is not the culprit in flexion deformity at all. The PCL is actually your friend. So, in any deformity which is less than 20 degrees, try and retain the PCL and do the standard principles, and then most of the times if you correct the coronal plane deformity, the sagittal deformity automatically corrects. So, that is what you must look at. So, flexion varus, this is typically the situation where you have a defect, you have a flexion varus, there is a cupola sign on the posterior tibia, there is a hypertrophy of the femur into this particular defect through the osteophyte, and this causes location of the femur and it causes the flexion deformity. So, in these cases, removal of these osteophytes alone with a tibial reduction, posterior tibial reduction will automatically correct it, and this must be recognized. The varus correction precedes the posterior capsule release or additional distal femoral cut in these situations, and the release here is not from the femur, it is from the tibia. So, you must do the posteromedial tibial release if at all you want to do any release, because that is the culprit there. So even if you have removed all the osteophytes, still flexion deformity is persisting. Do a little bit of release on the posterior aspect of the femur, because that will take care of both the coronal plane as well as the sagittal plane deformity. Coming to the flexion valgus, again here the ITB is at fault. So your ITB is contracted, and ITB is the structure which needs to be addressed in order to avoid the flexion deformity. So because ITB will correct both valgus deformity as well as the flexion component of the deformity. If you don't do an adequate ITB release, sometimes the flexion deformity will persist. But if you do an ITB release which still the flexion deformity is persisting, then what I do is I do a lateral partial condylar slide, distalize and posteriorize the condyle and fix it in that position, and that will allow us to take care of these complicated situations using less constrained implants. Now, the inflammatory arthritis, those associated with bilateral hip pathology, those associated with childhood pathology are completely different ballgame. So they should not be equated with whatever I told you so far. In these cases, physiotherapy, traction and wedging casts don't work. Posterior release preoperative is not a good idea. And in these cases, sometimes despite your best efforts, you will still have some amount of residual flexion deformity. And these patients take up to a year to completely become all right. So that's the posterior release in these sort of situations. And in grade 1 and 2 flexion deformities, up to 20-25 degrees, you can use both PCL retaining as well as PS depending upon your choice. In grade 3, you can use an anterior stabilized or a posterior stabilized prosthesis. But when there is extensive release requirement and significant distal femoral cut done, that is when you will have to increase the constraint to a constrained condylar or a hinge type of prosthesis. Why? Because these will tolerate joint line elevation up to 1 centimeters. The PCL retaining prosthesis do not tolerate joint line elevation. PS tolerates up to 4 millimeters. The constrained TC3 type implants tolerates up to 6 to 8 millimeters, while a hinge can tolerate up to a centimeter of elevation of joint line. So that will take the algorithm. And this is a case example. And these cases are not very straightforward. They are complicated because of osteopenia and all sorts of issues. And despite your best efforts, soft tissue releases, you may end up putting a hinged replacement, and this will go for prolonged rehabilitation. And you must not promise the patient, especially those with juvenile arthritis having both hip involvement, both knee involvement, about early recovery. This will take up to a year for complete recovery. Thank you very much.
Thank you, Krishna Kiran. Any questions from the floor?
Yeah, Krishna, the sagittal plane of the deformity tends to recur in the same plane. So hyperextension will tend to go into hyperextension and FFD will tend to go into hyper. So I think we should brace them well. Yes. And they'll need real supervised rehab.
Absolutely. So the FFD in our unit for the rheumatoid patients, we always put in a knee brace for them for the 3 or 4 weeks, because the quadriceps itself is weak. And if the quadriceps is weak and hamstring is overacting, they will get a recurrence of deformity. So that's a very, very good point.
Dr. Kiran, you use a lot of medial pivot knee. So what's your experience in this kind of situation using a medial and highlight few points advantage of using medial pivot knee? Thank you.
So it is not specific to any flexion deformity type of situation. It is about the function of ACL and PCL in a knee. So most of the CR knees have PCL, but they still do not have the ACL. So if you do a kinematic alignment or a restricted kinematic alignment, I have noticed that 4 to 5% of these patients demonstrate symptomatic knee instability, especially during stair climbing. So this is because you have done the kinematic alignment too well, and they try and replicate native knee kinematics, so they demonstrate the pivot shift. So the role of medial pivot is, because of the elevated posterior lip, it will to some extent replicate the function of anterior cruciate ligament. So it will give more stability during descending of the stairs, ascending of the stairs, and it will eliminate this sort of symptomatic sudden ACL deficiency type of symptoms. 95% don't have, but 5% of all cruciate retaining knees, they come back with some sort of a instability because of ACL deficiency. So the role of medial pivot is not so much in flexion deformity, but it is overall you must think about it as a go-to knee for any primary knee replacement, because it will allow for some amount of PCL stabilization through the anterior lip and ACL function replication through the posterior lip on the medial side. So that is what is the step.
Thank you, Dr. Krishna Kiran. Next, I call upon Dr. Thirumalai Sami for his talk on time-tested principles in complex total knee replacement, pre and post robotic era.
At the outset, I thank Dr. David Rajan, Dr. Yuvraj, and Ortho-One team for inviting me to this wonderful meeting. Chairpersons, dear Pari and Selraj, dear friends, the topic Dr. Yuvraj gave me was to know about the time-tested principles of complex primary knee replacement, whether it has changed after introduction of robotics.
So in our audience now, how many of us have a robo? Yes, Monty sir, anyone else? Yuvraj on the pipeline, anyone else?
It's a compulsion.
Compulsion, sir.
Yeah.
Sir, he is going to speak. I'm asking the audience.
I think there are so many, almost every major company has a robo, but I recently heard that Chinese company is coming out with a very cheaper robo.
Oh.
It's going to be an open platform. The cost is kind of 25 lakhs or something.
Okay, sir. It's something like the Pixel, cost is less than Pixel then. Yes, sir? 10 lakhs. Okay. So, actually, if you see as a surgeon for youngsters and budding surgeons or people who have to decide for the hospital whether they have to buy a robo, what is your advice, sir? In Delhi, how do they go about? Will they buy a robo now or wait for another 6 months? What do you say?
Everybody is buying a robot. Nobody is waiting.
Nobody is waiting.
So can I add something?
Yes, sir.
So we have a software now. It is very much in India. And this is basically a navigation software which enables you to do a complete preoperative plan, as well as you can use intraoperative HoloLens to do the navigation. I'm going to show that in my slide. But since you asked about the compulsion of having robo, it is not possible for every orthopedic surgeon to own a robo. That's one. Second thing is, when you buy a robo, it's like a marriage. So that you become company specific, mostly, if it's not an open platform. While what we would love to give you is a software as well as navigation, which is an open platform. So let's see. I'll show that.
Thank you, sir.
Thank you.
Now we are ready for the time-tested principles in complex primary TKR, pre and post robotic era talk by Dr. S.G. Thirumalai Sami.
Thank you. we all know that the primary knee replacement has reproducible good results, but in complex cases, the complication rates are relatively high. It could be up to 40%. What are complex primary TKR? A patient who has many previous operations and incisions, severe coronal deformities like 30-degree or more than that valgus or varus, severe flexion contracture, genu recurvatum, stiff knee, arthrodisc knee, extra-articular deformities and previous osteotomy, chronic dislocation of patella. We have enough problems to start with, and do the robotic assistance, will it help or it's going to compromise our results? Takes longer time, and majority of the time still with a complex situation you should, I personally would feel that I should go for the mechanical alignment and not using the robo. But there are certain indications which are really helpful. If you have robo, we can utilize that. The basic principles are correct component alignment, position and minimal bone resection, judicious soft tissue release and balancing of the knee is vital for any kind of knee replacement, particularly for the complex primaries. Let's see some other cases here. Bilateral OA knee, wind-swipe deformity, severe valgus on the right side and varus on the left side. If you need to correct both at a time, sometimes you might use, majority of the time if you could carefully release the soft tissues and go slowly, you may end up doing regular PS or CR knee, but sometimes you may have to use a stem or constraint insert in these situations. Pre-op assessment, clinical assessment is vital. Look for lateral thrust, and sometimes the MCL is completely off, and clinical examination is very vital so that you keep your implants on table, you're not surprised on table. This patient had an injury almost a couple of months back with a severe varus deformity. You can assume that MCL is completely gone. In this situation, you are aiming at a hinged knee on the right side and possibly a regular knee on the left side. When you do intramedullary fixation with the stem extension on both sides, on both knees, sometimes you end up in having complications like pulmonary fat embolism and serious post-op problems. In this situation, I used a regular mechanical alignment on the right side with a hinged knee and robotic kinematic alignment on the left knee to reduce the amount of blood loss as well as soft tissue injury on the left side, so that patient is benefited in this particular situation. Suppose if you have to use, particularly on both sides, intramedullary rod extension, be aware fat embolism can happen, and we recently lost a patient who had a similar surgery. This is another complex primary in which you can see the stress fracture on the tibial side, and even though the OA looks minimal, patient had, because of chronic varus load, she had additional tibial fracture. You need to fix that as well. Robotic assistance may not be of much help except cutting the proximal tibia, but you have to put tracker pins on the distal tibia, which already has a fracture. So I wouldn't advise, my principles will not change in this case. I'll just go for a regular knee replacement with the stem extension to take care of the stress fracture. This is again severe bilateral varus deformity with gross condylar, possibly condylar, medial condylar bone loss, and possibly stress fracture at the proximal tibia with hypertrophic medial femoral condyle. All these things would warrant more of a mechanical alignment technique and possibly bone grafting, all these things. I wouldn't go with the robotic assistance in these kind of situations. And this gives straightforward 1 hour surgery or 1 hour 15 minute surgery. You'll get a good results. You're happy. A similar situation, and again, I'm not repeating the same thing. These kind of problems where you deal on table with adjustments, which is not the robo is fed with. Robo is fed with majority of the knees and not these kind of extreme deformities. So you may end up in adjusting a lot of time. You might be wasting a lot of time to calculating the amount of resection if you are taking the assistance of a robo. This is again a severe coronal deformity, severe valgus deformity, fixed. Already you have seen some of the results before, and lateral MCL is grossly elongated, and lateral approach. This patient underwent. Okay, it's okay. It's okay. Doesn't matter. In these situations, again, I wouldn't go for a robotic assistance because you need to put the stem in, and if you have a tracker pin in the proximal tibia, you can't insert the stem. Then you have to remove the tibial pin, tracker pins before inserting the stem. So this is kind of extreme situations. We are quite happy with the regular mechanical alignment without any assistance. No way you can do robotic assistance in this kind of juvenile arthritis where both hips arthrosis, both knees arthrosis. So there is no way you can do these things. These are all going to be a standard basic principles oriented surgeries, and we'll still stick on to those things. And there is no movement in either hip or knee on both sides, and actually on the right elbow as well. And this patient had staged, if you want to do robotic assistance, you have to do all these measurements where it's impossible to do these kind of situations. And this patient had bilateral hip as well as one side knee, and the other side, when we did the second knee, patient developed fat embolism, and we had to abandon the procedure. At the end of the day, we had to redo it, but that knee we have to do only arthrodesis. So still patient could walk, and it's almost 14, 15 years follow-up. These kind of extra-articular deformities where there is minimal deformity but you can't use the intramedullary jig. Either you can go for a computer navigation or handheld navigation like this, or robotic help, where without this kind of additional help, you can't do proper cut of the distal femoral as well as the proximal tibia, and this is an ideal situation where robotic help is needed in this kind of extra-articular deformities with the previous trauma and a lot of femoral flexion deformity as well as varus deformity. In patients who had previous tibial osteotomy and implant inside with the proximal tibial varus, you can remove these implants and you can use the robotic assistance to get appropriate cuts and minimal soft tissue dissection. And these are the situations where these robotic assistance will help and you'll get good results. So to conclude, in case of severe deformities with excess bone loss and severe soft tissue contracture, stick on to the basic principles of TKR, like getting the mechanical alignment rather than going for this functional, kinematic, all these altered alignment techniques. Do not make complex TKRs more complex, inviting robo's help. In selected cases of complex primary, robotic TKR has a place. Robotic TKR seems to helpful in simple TKRs in terms of alignment, reducing the outliers, early functional recovery, and possibly long-term benefits. Thank you.
Thank you very much, sir. Any questions?
I just want to ask any other views. Anybody has any other views, for those who use robotics for these complex situations?
Rex sir, you want to add anything, sir?
I think we are in the initial phase of learning how to do with a robotic surgery for a proper knee replacement. And I'm sure in future, in 3-4 years time, we will also come to some idea, how to do for severe deformities or the extra-articular deformities what you showed. Definitely it's got a biggest advantage of, and other than the conventional instrumentation, you can use the robotics. But now most of our cases, they come with severe deformities, with the ligament loss and all those things. Many times conventional definitely has got a big role. And I'm sure the conventional will last longer, and robotics is just an added tool for you to make sure that what you're doing is perfect and with more accuracy. And we are trying to aim at 95 to 97% success rate, which we are not able to achieve with the only conventional. So that is how you should look at. It's not that all the cases you can do robotics.
Yeah, we are all, in India, we see a lot of these extreme deformities, and we have been treating for more than 20-25 years. And we have seen the results of conventional technique, which is quite good. So there is no need to jump in and invite another problem when we are not sure.
In your experience, in which of the cases or you would override the decision of the robo on table? Any chances that you have?
Yeah, that type of robo we have, the Corey Smith & Nephew, where you can also use the mechanical instruments and check it. Initially, when we started the cases, I didn't completely believe the robo because we had a fear whether the robo may be wrong. So every time we can always check with the manual instruments, make sure things are all right. So in that case, in that particular system, it's good. It's not semi-automatic, it's semi-automatic. Some of the robots are fully automatic, and I have not used it, but it's kind of some fear whether this will end up in wrong cuts and other things. But majority of the times what we see with the semi-automatic robo, almost 95% of the cases it's correct only. 5% if there is any deviation, you can override the robo and do the manual surgery. And always, even if you do the manual surgery, you can again check at the end of the surgery, you can check the alignment and the range of movements, any flexion, mid-flexion instability, everything can be checked. So in that gives a sense of satisfaction for you that this patient, we have done a good job and it will do well.
Mohanty sir, you want to add on this point? Yeah. You agree? Okay. We'll go to the next talk. Thank you, sir.
Thank you, sir, for a message to the audience was very clear from TMS, sir. To the delegates, stick to the basics, and the conventional method works in a majority of the time. And never jump into the technology, but follow the technology, but you have to stick to the basics. Thank you, sir. Thank you. Thanks.
Robot has reduced the soft tissue release. That is number one. Number two, this what he told that about mid-flexion instability. You can check the gap in 40 degree, 60 degree flexion, which you are not able to assess clinically, just roughly, but robot can show you the degrees. So those are the things. And you can take the cuts, like suppose extension gap is tight on somewhere, then you can give 1 degree varus to tibia or 2 degree varus, so balance that extension gap. Flexion gap type on somewhere, you rotate the femoral component accordingly. So those adjustment, fine tune, definitely robo has got an advantage. So thank you, Mr. Chairman, and thank you, Dr. David Rajan and Yuvraj and team Ortho-One for inviting me here. So my job is to talk about genu recurvatum. Friends, when the knee extension is more than 5 degree, it is told as genu recurvatum, and it is told to be severe when it is more than 10 degrees. That's what the literature say. Traditionally, it is very rare. It used to be less than 1% of patients undergoing knee arthroplasty. However, after the invention of computer and the robo, now the incidence of genu recurvatum before surgery is to the tune of 3.5 to 11.8%. That is shown in the literature by Mullaji and CO et al. But the recurrence after a deformity after the total knee arthroplasty in non-neuromuscular cases is about 3 to 4%. Whereas patients with associated neuromuscular problems like poliomyelitis or paralysis, the recurrence rate is extremely high. That is 50% of these patients, there is recurrence of the genu recurvatum. So commonly, as I told you, there is a neuromuscular disorder, post-polio residual palsy or some kind of paralysis, but it may be associated with other deformities. Like suppose there is a equinus deformity of the ankle with a weak quadriceps, that leads to hyperextension of the knee and genu recurvatum deformity. It may be associated with genu valgum where the IT band tight which is attached anteriorly or anterolaterally. So that may lead to genu recurvatum, and sometimes severe genu varum deformity commonly may be associated with a genu recurvatum. And post-HTO cases, when there is a reversal of the tibial slope, that leads to also genu recurvatum deformity. Sometimes there may be a bone loss associated, especially in post-traumatic situation or rheumatoid patients, this deformity might be there. And after doing a knee replacement surgery, suppose there is an extensor mechanism deficiency, fracture patella or something like that, then there is a genu recurvatum deformity. So these are the scenarios which we are going to discuss about it in this presentation. So pathology basically, if there is a bone loss like this or there is a reverse tibial slope like this, but there is no associated arthritis, it needs to be addressed with a flexion osteotomy of the tibia. But there are soft tissues, problems associated. There is weak quadriceps, there is stretched out posterior capsule of the knee joint, there is a tight IT band, and it has been shown that the distance of the collateral ligament from the to the attachment of the joint till it is less compared to the distance of the collateral attachment to the posterofemoral condyle. That is how it remains anterior to the sagittal plane, and hence it gets tight in hyperextension, and that way the knee goes into hyperextension. So if there is a such kind of problem is present, then you need to correct it by detaching the epicondylar attachment and pressing it more little proximally or little posteriorly, so that genu recurvatum deformity can be corrected. What are the implants you need to use? Though literature shows many authors have used CR knees, personally I would not prefer a cruciate retaining knee, genu recurvatum, because there is high chances of recurrence. So hence it is out of my selection. But most of the cases can be handled with typical posterior stabilized kind of knee, and this is the choice of implant because that will prevent at least hyperextension due to cam and post mechanism. But in some cases, rotating hinge knee can be used because of this inbuilt anterior stop that prevents hyperextension, and it transfers the forces to the bone implant interface, and rotating hinge especially dissipates these forces without putting stress on the hinge mechanism. That is why rotating hinge is preferred in genu recurvatum compared to a fixed knee design or fixed hinge design. So it is selected cases like neuromuscular disorder, or whenever there is extension mechanism deficiency, I would prefer to use a rotating hinge knee. So intraoperatively, measured resection technique, so you take suppose equal amount of cut from the distal femur and as well as from the posterior femur, so there will be normal flexion gap, but there will be increased extension gap, and that may lead to recurrence of hyperextension. So your aim during surgery is to reduce the extension gap as far as possible, and that can be done by resecting less of distal femur, maybe about in a couple of millimeters less of distal femur resection with a thicker polyethylene which can be used. But there is a possibility of alteration of the joint line. As Krishna told you that a couple of millimeters of joint line elevation, it may not affect the knee biomechanics as long as your knee is balanced, and depending upon that how much joint line alteration is taking place, you may select upon using your type of prosthesis or type of constraint of the prosthesis. So this is a patient, 72 years old female, osteoarthritic knee, genu valgum. That is her pre-operative gait. That is the X-ray we showing almost 30 to 40 degree of genu valgum deformity with a hyperextension and just only less of distal femoral resection and doing a posterior stabilized knee. That is the outcome of this patient with the full range of movement, restoration of the balance of the joint. That is 7-year follow-up of this patient. Whiteside, in addition to resecting, under resecting the distal femur, he suggested that to do a over resection of the posterior femur and increase the posterior tibial slope along with that. So, and if required, you may use the augments to build up the flexion space and distalize the joint line. So you need to keep also the constant knee in your theater so that you can address this condition. This is a 56-year-old male non-union lateral HOFA fracture with a valgus recurvatum deformity again. So this is a typical situation. This is the CT scan which is showing there is a recurvatum along with the non-union of the Hoffa fracture. So the Hoffa fragment was mobilized and fixed with Herbert screws and built up with the screws and cement there in the defects. That is the post-operative X-ray of this patient, and that is almost 6 years follow-up of this patient with again posterior stabilized knee with a full range of motion, and there is no recurrence of the genu recurvatum, and knee function is restored. So if there is a genu recurvatum with a fixed deformity, there you can do a lateral epicondylar osteotomy and shift it little distally and do a posterior fixation that balances the gap and restores the biomechanics of the knee. Of course, this condition, this procedure should not be done in presence of a neuromuscular pathology. So this is one of the rheumatoid patient, 53 years old female genu recurvatum with lateral epicondylar osteotomy, which has been fixed little, distally and posteriorly, and that is the outcome. This is again a, post-STO recurvatum in 65 years old male, where there is an anterior tibial slope and recurvatum, and that has been addressed by taking a, tibial cut with giving the posterior slope there, and that is the outcome. And in 2022, that is 17-year follow-up of this patient after the posterior stabilized knee. Now finally, the rotating hinge knee. It's a primary option in neuromuscular disorder like poliomyelitis or paralysis. It increases the load transfer to the implant, but especially rotating hinge knee, it decreases the shear force and transfers the load to the joint surface rather than onto the hinge compared to a fixed hinge design, and hence prevents early failure of the hinge mechanism. But it should be used as a last resort in other type of recurvatum. This is one of the patient who had a total knee arthroplasty done, sustained a fracture patella, there is failure of fixation of the patella, and that is a 68 years old male, and this is the instability mediolaterally. This is anteroposterior instability. In this kind of patients, you need to use a hinge knee in order to address this problem. Then patella was fixed with a fiber wire, and subsequently semitendinosus was used to reinforce the patella fixation, and that is the outcome. That is a 3 years outcome of this patient, restoration of the extension of the knee, and that is the function of this patient. Post-operatively, always leave this patient with some amount of FFD that eventually stretches out in due course. Give a gait training. Sometimes you may require this hyperextension prevention kind of brace. So this brace helps you to gradually correct the deformity. What the literature says, there is scarcity of literature about the genu recurvatum correction. These are the literature which shows, these are all retrospective studies which shows that some surgeons use CR, some used PS knees, and they are all osteoarthritis and rheumatoid patients, and amount of genu recurvatum was around 8 to 11 degrees, and there was almost no incidence of recurrence. Only 2 cases had little recurrence of recurvatum. And what about total knee arthroplasty in poliomyelitis? There are only 82 cases which has been reported in this 6 series literature. There are cases, the age group is usually 50 to 60 years of age, and the follow-up period is about 3 to 6 and 7 years maximum. And they used most of them are used posterior stabilized knee, some used RHK or CCK type of knee, and the quadriceps strength was almost 0 to less than 3. And there are recurrence of recurvatum in almost many cases, 38% here, 25% here, 25% here. So the outcome is poor, and revision rate also extremely high, that is 33%, and here is 10% like that. So to conclude, dear friends, genu recurvatum is rare, less than 1%, but with the navigation and robot, the incidence is becoming high, that is 3.5 to 11.8%. Under resect the distal femur, use thicker polyethylene to reduce the extension gap, do a lateral epicondylar osteotomy in case of fixed deformities. If there is no neuromuscular weakness and there is anti-gravity quadriceps, that means quadriceps power is more than 3, then use a non-constrained conventional PS type of implant. But if there is neuromuscular weakness and the anti-gravity quadriceps power is not there, prefer a constrained implant like rotating hinge knee, and the outcome is comparable with other arthritic conditions. I thank you for a patient hearing, and I request all of you, those who have not done the updation of the IOA data, tomorrow is the last day, so kindly do the updation online through the link which has been sent by the Ernst & Young company. Thank you for a patient hearing.
Thank you very much, sir, for a wonderful talk. Now I have you've been very clear in saying that we need to do a PS knee in case of Rakavatam.
Yeah.
Dr. Anup and Bala sir and others here, would you like to concur or differ with that? TMS sir, what do you think? Should you do a CR knee or a PS knee? There, the mic is there. Mic is there.
In Reconstruction, the extension gap is more, flexion is tight. If you leave the PCL intact, still the flexion is tight. So if you remove the PCL, you get a flexion gap open so that you can match extension and flexion. So I always do PS knee in Reconstruction deformity.
But
that's the reason.
Is PCL not a restraint against Rakavatam?
That's right. That's right.
Normally we would think that we should retain PCL because PCL is going to prevent Rakavatam if we keep it. I mean, what do you think?
But it doesn't allow to correct the deformity.
Okay, so.
No, so depends what the cause of recurvatum is. If it's neuromuscular or something patient is high diabetic, recurvatum especially more than 10 degrees, then you need to go on some constraint. But normal 4-5 degrees of recurvatum, which is mostly due to bone loss, anteromedial bone loss, which takes the knee into recurvatum, they can be beautifully managed with a cruciate retaining knee.
One more point also that in a CR knee, it helps us to keep the knee little tighter. If you do a PS knee, it again stretches out very quickly post-operatively. So in a CR knee, because the flexion is already tight also, and if you keep the extension by bringing down the femur with the distal augments, you can keep the knee tighter so that post-operatively the stretching part is.
If at all you are using a CR knee, then you may use an anterior lift, insert, deep disc insert, that may be preferable. But personally I don't prefer, but literature has shown many authors, they have used also CR knees in recurvatum deformity.
Thank you, sir.
Thank you.
This is a never-ending debate, and proponents of CR and PS are always going to promote their ends. And next talk.
Invite Dr. Rex sir to talk on retained hardware and deformities, TKR and post-traumatic arthritis.
Good afternoon, respected chairperson and friends. At the outset, I thank Dr. Yuvraj and DVS sir for giving this opportunity to talk on how to overcome a retained hardware and the deformities due to post-trauma arthritis and how to perform TKR in this difficult situation. So always we see a small subgroup of patients with post-traumatic arthritis with the implant on. And sometimes there may be associated malunion with deformity as well. And we all know the phrase, no one looks good taking out hardware. And this complicates the case, and there must be a careful decision making whether to remove the implant or not. So the most common reason for post-traumatic arthritis leading on to patient getting for a TKR is the malunited femur. It's not the tibia most of the times. If you even see the literature, every day you may see tibial plateau fracture, but how many tibial plateau fractures comes for TKR is very, very less. So the literature is very clear that most of the malunion of the femur is a problem, and these cases they end up with arthritic knee. And surgeons always have the problem of how to deal with this, and the problem correction of the malunion, and the problem integral problems like non-union infection and so on. With the advent of robotics and navigation as techniques, there is an alternative approach than the conventional way of doing a TKR. So this makes our life easier, which is less invasive and very effective. The first principle, when you have an implant, the implant on your way for implanting TKR must be removed. This is an obvious fact. Okay, this is the first principle if you have an implant on. When the implant is going to be on your way of implanting, you must remove those implants. The simple example is, this is a case of the patient who had a nailing done for the tibia fracture and for a posterior for bilateral TKR. So we did a good preoperative planning, and we thought this may not interfere with our routine conventional TKR. And so only the proximal screws were removed, and we were able to perform a good knee replacement without removing the implant. So
always keep the surgery minimal. You don't need to venture for removing the implant. The removal of implant may cause a periprosthetic fracture, or it can lead on to infection. Signs of infection is also pretty high. The second principle, the implant on the way of for the jigs or for the preparation can be left alone if you have an alternative way of doing things like navigation or robotics. Obviously, if you don't have a choice, then you need to remove the implant. So this is the second principle which you need to follow. And a lot of literature has come now with the pointing that we can use the robotic or the computer navigation in these sort of difficult scenarios. This is one of the case examples in the literature, where with a locking plate with so many implants on, and removing this implant is going to be, it is going to be time, a lot of time will be wasted and a lot of blood loss. So if you have a navigation or robotics, your job is easily done. The third principle is, if you are in an osteoporotic bone, if you remove an implant, there is a high chance of post-operative periprosthetic fracture on the femur side. Lot of, case reports are there. So my principle is always minimal screw removal and leaving the rest of the implant is a good choice. Otherwise, if you have an implant that need to be removed in total, then a stemmed implant which should span across the screw side is very important. Okay? Otherwise, in the post-operative period, you should mobilize, with a partial weight bearing, not a full weight bearing. So you need to understand the periprosthetic fracture is pretty high, especially if you remove the implant from the femoral side. A lot of literature, there is a complication cascade following removal of implant and a TKR, and then patient again going for a periprosthetic fracture and implantation. So you don't want to run into all these problems. When you have an implant and whether you want to do two-stage or a single-stage procedure, that is another big debate. Single stage always is preferable because you can remove the implant and then do a TKR on the same sitting. But there are certain indications when you want to do a two-stage. The first important thing is if you think that the implant is going to be taking a long procedure, is going to take long time, or is a long-standing implant, the removal can be difficult. It's going to take hours together. Better not to do it in the same sitting, the TKR. If you have sclerosed bones covered, again, it's going to be a tough procedure. Then infection is absolute contraindication to do the same in the one sitting. And if you have a big extraarticular deformity or leg length discrepancy, then obviously you need to do a two-stage, remove the implant and do a planned TKR later. So what is the disadvantage of doing a single stage? The biggest disadvantage is you have to use multiple incisions if the implant is way away from the TKR incision, or you need to have an extensive big flap which can cause skin necrosis and wound problems. And obviously, whenever you remove an implant, take a culture and sensitivity to make sure there is no any dormant infection there. And chance of contamination infection is pretty high. And if you're going to remove the implant, and as I said earlier, you should use a long stem which should span across the screw side to prevent periprosthetic fracture. Now coming to the deformities, you see malunited fractures with deformities, and there will be overlap with the previous talk by Harish Bindre. And the deformity can be intra-articular, extra-articular combined, again in different planes, and translation can be there. The biggest challenge when you want to correct all these intra-articular, the general dictum is up to 25 millimeter of the femur, distal femur, we can remove safely without touching the collateral ligaments. And in the tibia side, maybe up to the neck of the fibula, okay, the head of the fibula. So not below that. So you need to understand this. So if you're going to do this, there is going to be a big imbalance in the soft tissue. Okay, so gross deformities you cannot do intra-articular correction. And so good preoperative planning with the long leg film is very important. So orthoscanogram is important, and do a CT scan. Do all these lines. Do a mechanical axis with the hip knee ankle axis. Do a LDFA and MPTA, and see the cora where the deformity lies. And the classical paper by Wang et al. Said the femoral side up to 20 degrees you can do intra-articular correction. On the tibial side is up to 30 degrees. And Deschamps also said the same way. Any sagittal plane correction up to 15 degrees you can do very easily intra-articular. And axial, any rotational deformity, 100% you cannot do any intra-articular correction. It need to be extra-articular. So Intra-articular correction, with these indications, if you have the extra-articular deformity far off from the joint, you can get away with intra-articular correction, provided the bony cuts doesn't damage the collateral ligament. Okay, so this paper is very classic paper. Everybody should know this. The mechanical axis of the femur, if you draw a line, and if you see that perpendicular to the mechanical axis on the distal femur, if it is above the collateral ligament, you should not do intra-articular correction, it should be extra-articular. Similarly, in the tibia, the distal diaphyseal long axis, you extend the line up. If it cuts on the tibia, you can do. If it is above, outside the tibia, you need to do extra-articular correction. So, so obviously, as I said earlier, this is one of the examples. This is a malunited tibia and less than 25 degrees of deformity. So intra-articular correction with the stem extension. So the sagittal plane, as I said earlier, up to 20 degrees procurvatum, recurvatum, you can manage without much of an issue. The one fact you should understand, in the intra-articular correction, when you touch the femoral side for corrective correction of the deformity, you can do the balance only in the extension. You cannot do the flexion balancing. The same thing if you do on the tibial side, you can get both flexion and extension balancing. So the advantage of doing a single stage total knee arthroplasty with osteotomy is a single surgery, easy to balance, reduce cost. All these are easy but technically demanding and a long surgery. Obviously, you do the osteotomy first and then TKR, not the other way around. And this is a simple example. As a supracondylar malunion, you do a good preoperative planning with a long stem extension with a chevron osteotomy to lock, so to have a controlled rotation, you can get away with a long stem TKR. The extra-articular deformity again very close to the metaphyses. You can use sleeves or stems to correct those deformities. This is one of the examples of varus knee, varus on the supracondylar varus deformity. So with the osteotomy in the supracondylar area, with the stem put on, we can get away with a good correction and do a TKR. When do you want to do two-stage? If there's severe extra-articular deformity or a limbal discrepancy, you do osteotomy, wait for the bone healing, and then do a TKR. Okay? So if you're doing an osteotomy, the diaphyseal osteotomy, if you're going to do, you need to check the implant whether it's going to be on the way for the TKR for the second procedure. So try to avoid the implant coming closer to the TKR. So locking plate or IM nail, whatever it is. And open technique is better than the percutaneous techniques. Robotics has got a good, big say on this, and because you can get your mechanical axis right, the most important is the joint line orientation. You can get it better with robotics, which is not possible with the conventional manner. And this is our example. This is the tandem deformity on the malunited lateral condyle of the femur and the middle condyle of the tibia. But if you see this mechanical axis is right because of the tandem deformity on the diagonally opposite deformities. And so we got away with the good balancing with the thicker insert, good stability preoperatively, and so the primary arthroplasty without any stem extension was done. And if you have this is a malunited midshaft tibia because of stress fracture, so I need to use a percutaneous osteotomy to break correct the deformity and then use the long stem. The stem must cross at least double the diameter of the osteotomy site or the fracture. This is another example for malunited supracondylar fracture femur, 25 years old malunion. This patient kept on walking to a stage when the MCL gave way. So that is the stage when he came to us. So we know definitely he's going to use a hinge knee because the MCL is no more. And we did a good preoperative planning. So the offset stem on the femur, we were able to negotiate and get it right. This is again a malunited tibial condyle, and if you see the trajectory on the tibia, it's going to be more lateral when you put a stem. So we needed an offset stem on the tibia to get it right. Without you need to be less constrained most of the times not to use a hinge. And this is again a malunited upper tibia. The same this patient again came to a stage when he had a pathological fracture medial tibial plateau with the OA. So again, the offset stem on the tibia on the tibial side with a good preoperative plan, we were able to get away with it without any constraint. So if you see the results are slightly inferior than what you do for TKR for a primary OA knee. The reason being instability and arthrofibrosis. So my take-home message from this is you should do a good preoperative planning. It's very important when there is a hardware or a deformity. You should have all the the inventories on table. The armamentarium should be ready so to choose whichever you want to do, and retain the hardware wherever possible to prevent any periprosthetic fracture. Robotics and computer navigation has got a role. Intralear correction most of the time surfaces, and there is extended indication with the robotics, even you can do up to 25 degrees of correction than the conventional 20 degree which was accepted previously, and the outcomes are sustained over time if planning and execution is done as what we want. So thank you everyone.
Thank you, sir. Any questions from the floor? Thank you, sir.
Thank you.
Next we call upon Dr. Vikash K. Jain for his talk on 3D technology and transforming. The new technology is the technology that is transforming us. A 3D technology, a new concept. Welcome you, sir.
So, thank you so much. Thank you, organizers, Ortho-One, Dr. Yuvraj, Dr. David, for having invited me. In the last penultimate talk, I'm more of a technology surgeon now than an orthopedic surgeon. So for last almost 3 decades, I have been an orthopedic surgeon. And with the changing times, I have decided to at least diversify myself into technology. The thing that is transforming is actually not the technology. It's the technology that is transforming us. And that is what is important for us to realize. This is what we do. We specialize into customization. We are into digitalization. We give digital solutions. And this is what the future into orthopedics is going to look into. So when Dr. Yuvraj called me, he asked me to talk on something to do with 3D technology and complex knee arthroplasty. And I was just thinking as to how to make this talk. Sorry. Let me tell you, friends, that the patient information that comes to us in 3D is not only for diagnosis. So what you do in CT scan and an MRI is not only for diagnosis. Now we can make products. We can bring the disease out of body. We can understand the complexities, and we can plan a better patient outcome. So this is how we have to look at the 3D technology. This is just not doing a CT scan or an MRI scan that will enable us just to make a diagnosis or take a better patient out decisions, but we can also use that further now. So there is a lot of things that you can do more with whatever information that we get from either a CT scan or an MRI. So to start with, what is this technology is basically anything that we get information in 3D. So easy for you to understand is that the information that comes to us from a CT scan or an MRI is actually a 3-dimensional information. So in cases of trauma, tumor, plasty, and pediatric, we can use this technology, and this is wherever you have a deformity or wherever you have a complex defect, you can use this technology. I'm reminded of a very beautiful saying, which is a Socrates paradox, which says that there's only one thing that I know, and that I know nothing. This is a paradox, and this is what it is. So what we think is that we know a lot. Actually, there is a lot to know more than what we know, and that is why we have to assume that we don't know everything. The second thing that is that what we learn is there is a stage when we need to even unlearn it, and we need to relearn it, because there's a lot that's going to happen in the technology field where we need to unlearn and need to relearn. So this is what I was talking about when Dr. Bende was giving his talk, and I told that there's a possibility that we can make jigs in cases of complex extra-articular deformities, or even in cases of primary knee. you can go in for making customized jigs. That is what you can do through a 3D technology. The other thing that 3D technology is enabling us is the phenomenon of osseointegration. Now, osseointegration is something which is very perplexing to all of us. What we want is that our implants should integrate very well with the bone, and the integration happens good when we 3D print an implant and we create a trabeculae, something like this, what you see in a picture. And this sort of a trabeculae, when it makes an interface with a bone, it integrates with the bone for sure. This is another challenge in a complex knee, even in case of a complex primary or a revision, that is bone defects. So friends, if you can study the bone defects, and from the bone defects, if you can make out that this is a type of a defect which by biological methods of bone grafting, if I'm not able to cover, can we make something which is out of titanium, which can be used as an augment, and these augments are those which are customized augments. So there are going to be complex situations where there are going to be complex defects in cases of revision knee arthroplasty. So revision hip, yes, on the acetabular side we have such situations, but even on the tibial side in the revision knee, you will find such situations. This is one case on the right hand side which you see is a customized tibial plate. What you see is a very reduced entire requirement for a knee arthroplasty. Here, the surgeon wanted to have a customized tibial plate with a trabecular extension, including the fit that would take care of the defect in case of a revision arthroplasty. So what you could see there is again a 3D printed thing. Also in cases of focal defects, where you can create an osteochondral plug, again doing a 3D study, 3D planning, and you can create a 3D printed titanium osteochondral plug, which can take care of the defect anywhere in the knee. Sorry. Now this is one case which I have done around a year back, where there was a young female which she had a avascular necrosis in the posterior one half of lateral femoral condyle. And what you see is a customized titanium trabecular implant which was made. This patient had an FFD knee. It was very painful. She was not walking for last 3 years. This was done along with a surgeon called Dr. Shantanu Anand, who's from Bihar. And this is the design that we gave. Now this is how the implant was fixed. And let me show you how the fluoroscopy looks. How is the range of movement in this particular patient who had an FFD. It's painless, complete range of movement, patient walking, full weight bearing. Currently the implant has osteointegrated well in the lateral femoral condyle. This was somewhere where the surgeon contemplated to do an arthrodesis. In cases of patellofemoral arthroplasty, again 3D printing can be very useful, where you can do a trochlear reconstruction. You can go in for a customized trochlear reconstruction and you can make a trochlear plate there. This will enable you the customized patellar tracking, so you may not go for an off-the-shelf implant. This is what I was talking about when I was talking in terms of having a software which is a navigation-enabled software, but it's not robotic. It's a humanoid robot where you can do a complete preoperative planning on a software for a knee arthroplasty. And here I'm going to show you exactly the use of mixed reality and an augmented reality in a patient where you can see. So what you see below is the use of HoloLens, and slowly you will see something green and you will see the preoperative plan of a tibia here, if you can see. This is mixed reality. This is actually a surgery performed by our software by an arthroplasty surgeon. While you see above is a complete planning that is happening on a software. What you see below is an intraoperative use of a augmented reality software where you can see an overlap. This is again 3D technology. It's a digitalization and use of the digital information coming from the DICOM, from the CT. So friends, the information that is consumed by us is just an individual or a collective opinion and an experience, and it is not an orthopedic wisdom. While we have a long way to go to understand the orthopedic wisdom, thank you, that's a point to ponder. We all collect here, and there is usually what we come out with our experiences, and there's a long way and a lot of things that can be done in future using digital technology in orthopedics. Thank you so much.
Thank you, sir. And thank Dr. DVR sir and Yuvraj for giving us this opportunity. It was a wonderful session, and moderating this session was a learning experience. Thank you.
Thanks very much for the opportunity. I take this opportunity to invite all of you to the COS meeting today evening at Hotel Grand Regent. Whoever is staying back, please come and join us. It is just opposite this hotel.
Thank you, Dr. Pari and Dr. Karthik. And we have a panel discussion. The moderator, Dr. Rajkumar sir. I would like to invite Dr. B.R.J. Sadish sir, Dr. Rex, and Dr. Muthusaravanan. And Karthik, please stay back for the panel discussion.